session at 5 o'clock. By the way, I am tickled pink. Next year they're going to do away with the common hour, and this whole class is going to shift earlier in the day. Yeah, I haven't really been happy staying down here until 6 o'clock at night. It'd be nice to shift at least a half hour, if not an hour earlier. But they're going to get rid of the common hour, which I thought was a terrible idea when they came up with it. Anyway, to have your classes in the morning was great. In the afternoon was a terrible thing. Any questions before we start today? All right, we'll go through our slides, and Michael can do the first one.
All right. Harry, a taxi cab driver, was found after an assailant attacked him with a knife and punctured his chest. When he was taken to the hospital, a chest x-ray and blood tests were performed, and he was treated for a collapsed lung. Afterward, Harry revealed himself to be a chronic cigarette smoker, and his physician ordered pulmonary function tests. Next slide. So this is a picture of a hematoma of the tongue following trauma. If the trachea becomes occluded through inflammation, excessive secretion, trauma, or aspiration of a foreign object, it may be necessary to create an emergency opening to this tube so ventilation can occur. What is the name of the surgical procedure, and what is the name of the opening that is created by this surgical procedure? Tracheotomy is the procedure, and what is the name of the opening? Tracheostomy.
Do I remember that? Because I know in hospitals they have what are called ostomy teams, and ostomy teams just take care of ostomies. They take care of the openings in people, like colonostomies or tracheostomies or whatever. So the ostomy is the hole. Yeah.
Next slide. A tracheotomy is the procedure of surgically opening a trachea, and the resulting opening is called a tracheostomy. Next slide. And this is a picture of a tracheostomy. Kind of crazy.
Next slide, please. A tracheotomy should be performed only by a competent physician because of the great risk of cutting a recurrent laryngeal nerve on the common carotid artery. Next slide, please. The elastic nature of the lung tissue is revealed when air enters the intrapleural space as a result of an open chest wound, for example. What condition occurs when air enters the intrapleural space following an open chest wound? Pneumothorax. Very good.
The condition of outside air in the intrapleural space is called a pneumothorax. Pneumo meaning air, thorax meaning your chest. As air enters the intrapleural space, the intrapleural pressure rises until it's equal to the atmospheric pressure. When the intrapleural pressure is the same as the atmospheric pressure, the lung can no longer expand properly. Not only does the lung not expand during inspiration, it actually collapses away from the chest wall because the parietal and visceral pleura are no longer stuck together with a partial vacuum, and the lung's elastic, and the whole thing collapses inward, as we see up there in the picture. What is the scientific term for a collapsed lung? A lot of people think pneumothorax and a collapsed lung are the same word. They're not. What's the word for a collapsed lung? Let's see the next slide, and we'll take a vote on this one. I call it atelectasis. Atelectasis. Anybody know if that's right or wrong?
I like it.
I came up with atelectasis. Anything else, my tongue fell out on the plate. Keep watching.
So the term for when a lung collapses away from the chest wall is atelectasis. Fortunately, a pneumothorax usually only causes one lung to collapse, since each lung is contained in a separate neural compartment. Next slide, please. Harry's stab wound caused a collapse of his lung. What condition does Harry have, and how might it look in an X-ray?
Just repeating.
So pneumothorax, and what's the name for his collapsed lung specifically? Atelectasis, or whatever we decided. So how did the stab wound cause the lung to collapse? Perfect. So there, air entered the thoracic cavity, got rid of the vacuum, elastic pressure, elastic recoil, caused the lung to collapse. Could Harry still breathe before medical help was given? Yes. How? Other lung. Perfect.
Before we go on, let me just answer questions asked. Go back one slide. Back another slide. Let's go forward one slide for a second. So we've got air in the intrapleural space. That's what your author calls the intrapleural space. We got out of there. And the lung has collapsed and we've lost our vacuum, right? Okay. Let's go back another slide, please. Back one more. See this hose? That hose goes into the intrapleural space. And the other end of this hose is a vacuum pump. So it should be pretty clear what they're doing here. If you vacuum out the air between the parietal and visceral pleura, hopefully they'll come back and stick to each other and get back to normal. So this is a chest tube, is what they call it, and it's hooked up to a vacuum pump. So does that answer your question? Okay.
The chest tube can also be used to drain blood or fluid that gets in the intrapleural space. Anything that gets in that space can cause a collapsed lung, not just air. But next slide. Perfect. The condition that Harry had was pneumothorax that led to collapsed lung, or atelectasis. His wound caused his lung to collapse because the air entered the intrapleural space. It allowed the intrapleural pressure to be the same as the atmospheric pressure. This allowed the suction between the parietal and visceral pleurae to be lost, and the elastic lung collapsed inward. Harry was still able to breathe before medical help was given because his other lung was not affected, since it was in a separate pleural compartment.
Next slide, please. Even under normal conditions, the first breath of life is difficult because the newborn must overcome great surface tension forces in order to inflate its partially collapsed alveoli. The transpulmonary pressure required for the first breath is 15 to 20 times that required for subsequent breaths. What condition of infancy causes this same amount of effort with every breath, and how is it treated? Good. Respiratory distress syndrome. And how do they treat that? Say that louder.
You give them exogenous surfactant.
Good. Exogenous surfactants. And there's something else as well. And a mechanical respirator. Very good. So exogenous surfactants and a mechanical respirator for those.
Next slide, please. This condition is called respiratory distress syndrome. Fortunately, many babies with this condition can be saved by mechanical ventilators and by exogenous surfactant delivered to the baby's lungs by means of an endotracheal tube. The exogenous surfactant may be a synthetic mixture of phospholipids, or it may be a surfactant obtained from bovine lungs. The mechanical ventilator and exogenous surfactant help keep the baby alive long enough for its lungs to mature, so it can manufacture surfactant on its own. Unfortunately, the administration of exogenous surfactant does not help treat adults with acute respiratory distress syndrome. Next slide, please. Bronchoconstriction often occurs in response to inhaled noxious agents present in smoke or smog. The FEV1 has therefore been used by researchers to determine the effects of various components of smog and passive cigarette smoke on pulmonary function. These studies have shown that it is unhealthy to exercise on very smoggy days, and that inhaling smoke from other people's cigarettes in a closed environment can adversely affect pulmonary function. There is normally a decline in FEV1 with age, but research suggests that this decline may be accelerated in cigarette smokers.
Do we have such a problem in Cache Valley? I believe they refer to them as red air days.
Mm-hmm.
And Dr. Ed Red, who's working on that at the Public Health Department. And he's advocating that when we have an inversion, that occurs in the wintertime, right?
Yes.
Okay? The kids not go outside because it will cause measurable damage to kids in this valley if they go out when we have high particulate matter during days of inversion here. I think we have some of the worst polluted air in the nation when we have inversions, is what I've heard.
Just when it was raining the other day, I was wearing a suit and it was mud everywhere just from the rain. Oh, it made me so mad.
Well, that was dust. That was dust.
Oh, it still is.
So, what happens to the FEV1 in persons who stop smoking? Goes up.
Next slide. Smokers under the age of 35 who quit have improved lung function. Those who quit after the age of 35 slow their age-related decline in FEV1 to normal rates.
So I think it's only saying the FAV goes up. I think it's better to say the FA goes back to closer to a normal value, because it's actually going to be able to expel things quicker in 1 second with a normal one. It takes longer So the number's higher when you have emphysema. So, sorry.
Next slide, please. Asthma is often treated with glucocorticoid drugs, which inhibit inflammation. Newer drugs that block leukotriene action, such as Singulair, are also available to suppress the inflammatory response. In the past, epinephrine was used in an inhaler to stimulate the beta-adrenergic receptors, ooh, they're coming back, in bronchiolar smooth muscle, and by this means promote bronchodilation, promoting immediate relief during an asthma attack. So why is epinephrine no longer commonly used for this purpose? Good, it stimulates all beta-adrenergic receptors, so beta-1 and beta-2. And what newer medication is used in its place? Albuterol, very good.
Did we talk about albuterol in the past? It's amazing how those things keep coming back. Next slide. Unfortunately, epinephrine stimulates both the beta-1 adrenergic receptors that predominate in the heart and the beta-2 adrenergic receptors in the bronchioles. So you're getting a mass effect there. More selective beta-2 agonist drugs, such as albuterol, are now used instead to promote bronchodilation without sending your heart into overdrive, like epinephrine does.
All right, next slide. Harry's pulmonary function tests revealed that he has a slightly low vital capacity and a significantly reduced FEV1. So what is the significance of this low FEV1? What is FEV1 doing? What is it testing? Perfect. So it's going to indicate he has obstructive pulmonary disorder. And what can he do to improve it? Stop smoking. What is the vital capacity?
What is vital capacity? Maximum inhalation.
Yep. So that's going to be the maximum amount of air you can inhale
And then exhale.
and exhale. And what could cause this to be slightly low?
Pneumothorax.
Yeah.
Is it low?
I guess pneumothorax could.
Yeah, yeah.
That's a good point. That's a fair point.
His lung was shot to hell, yeah.
But yeah, we'll go with that.
I guess a related question we haven't covered yet. What does FEV1 stand for? Because, you know, on your test it's half points for acronyms. What is FEV1? It's forced exhalation volume, and the one means in the first second of exhaling.
And you know, just kind of correcting myself there as I was thinking about it, you want a high volume of air to be expelled in 1 second. And so if you had a reduced FEV1, that means you have a reduced volume that you could exhale in 1 second. That's probably a clear way of saying it. I kind of said it wrong previously.
Next slide, please. The significantly low FEV1 indicates that Harry has an obstructive pulmonary problem, possibly caused by smoking and the inhalation of polluted air. A low FEV1 could simply indicate bronchoconstriction, but the fact that Harry's vital capacity, or the maximum amount of air that can be exhaled after a maximum inhalation, was a little low suggests that he may have early-stage lung damage, possibly emphysema. He should be strongly advised to quit smoking, and further pulmonary tests should be administered at regular levels.
Next slide, please. All right. A pulse oximeter is commonly used in hospitals for non-invasive measuring of oxyhemoglobin saturation. This device typically clips on the finger or pinna of the ear and gives readings of oxygen saturation and pulse rate within a short time, making it useful in many contexts, such as emergency medicine and during anesthesia. So how does the pulse oximeter determine oxyhemoglobin saturation?
Absorption.
Good. So absorption of the infrared lights. Oxygenated hemoglobin are going to absorb lights at a different frequency than deoxygenated. So are they using just one light, or are they using?
Red and infrared.
Good. Red and infrared. Very good.
I mean, the logic here is something you all did when you were kids. You shine a flashlight through your hand, and you can see the red. It's red because of the hemoglobin and your blood. And if you use the right wavelength of light, you can figure out how oxygenated that hemoglobin is. Next slide. So what Jurgen said, use two light-emitting diodes. One emits red light, and the other emits light in the infrared range, both of which pass through the tissues to a sensor, a photometer. And by doing these wavelengths, you can see what is absorbed, what materials in the blood absorb those wavelengths. And then you can figure out the oxygen level from that.
Next slide, please. Also, just an interesting note in case you didn't know, there are actually apps now for pretty much every smartphone that'll use the flash for your light and your camera that'll do it. I don't know how accurate they are, but it's kind of fun to use your smartphone and see what your pulse ox is. So oxyhemoglobin and deoxyhemoglobin absorb light differently in these ranges, allowing microprocessors to determine the percent oxyhemoglobin saturation fairly accurately under most conditions.
Next slide, please. Harry's arterial PCO2 was elevated when he was brought to the hospital, but after treatment it returned to normal. What caused the rise in his arterial PCO2?
He came in with a stat load, as I recall.
Exactly, hypoventilation. So the collapse of the lung led to hypoventilation, which raised his arterial PCO2. And how did this measurement return to normal after Harry's treatment?
They gave him 100% oxygen.
Basically, yeah. So once he returned his second lung back to normal size, it let him exhale more carbon dioxide. He was still getting enough oxygen intake, but he couldn't get rid of enough carbon dioxide with just one functioning lung.
It's almost like he had one half his surface area. He got the other half back.
So question then, if he has got an increase of CO2, would his blood pH go up or down? Down. Why is that? What was the name of the... Good, carbonic anhydrase, very good.
And that's a sign of what chemical phenomenon?
Oh, yeah.
Do,
I like that. No, what chemical
Chemical
shift.
Shift, yeah.
Shift that occurs.
It's a chemical law, in fact. The
Chatelain's
Chatelain's is
principles.
what chemists call it. In
Law of mass action.
the law of mass action is
Mass
what your
action.
textbook calls
Very
it.
Very good. Next slide, please. Yes. Because of his lungs, atelectasis, Harry was hypoventilating. This caused retention of CO2, causing his arterial PCO2 to rise.
That should be the last one. Next slide. Okay, Harry's PCO2 measurement returned to normal after his treatment, his chest tube, because he now had two fully inflated lungs, could properly exhale CO2. Though not stated in your text, Harry's lung was re-expanded by utilizing a chest tube. One end was inserted into the intrapleural space. The other end was attached to a vacuum pump to remove air from the intrapleural space. This would allow the pleural membranes to reattach. Okay? Next slide. And you guys can do this one.
Hyperbaric oxygen therapy, in which the patient is given 100% oxygen gas at 2 to 3 atmospheres pressure to breathe for varying lengths of time, is used to treat carbon monoxide poisoning, decompression sickness, severe trauma such as a crush injury, infections that could lead to gas gangrene, and other conditions. Next slide. While a normal plasma osmotic concentration of 0.3 milliliters O2 per 100 milliliters of blood, as previously described, breathing 100% oxygen to the pressure of 3 atmospheres raises the plasma concentration to about 6 milliliters O2 per 100 milliliters of blood. This helps kill anaerobic bacteria, such as those that cause gangrene, promote wound healing, reduce the size of gas bubbles, such as in decompression sickness, and quickly eliminate carbon monoxide from the body. Why is hyperbaric oxygen therapy no longer used to treat respiratory distress in premature infants? Perfect. Fibrotic deterioration of the retina.
Next slide, please. The practice of using hyperbaric oxygen therapy to treat premature infants with respiratory distress was discontinued because it caused a fibrotic deterioration of the retina that frequently resulted in blindness. And nobody wants a blind baby.
For those of you who'd like to write notes, the name for this condition, which isn't mentioned by your author, is retrolingual fibroplasia. That's probably worth knowing if you're going into a medical profession. It's called retrolingual
For your information, this condition is called retrolental fibroplasia.
All right, next slide. The automatic control of breathing is regulated by nerve fibers that descend in the lateral and ventral white matter of the spinal cord from the medulla oblongata. The voluntary control of breathing is a function of the cerebral cortex and involves axons that descend in the corticospinal tracts. What is the name of the disease condition when automatic but not voluntary control of breathing is lost? Ondine's curse. There's another name for it. Congenital central hypoventilation syndrome. How is it treated? Good. Mechanical respirator and constant reminder to breathe.
Don't forget to breathe. Next slide. I'd never heard about Ondine's curse, and I was just intrigued with this whole thing. Ondine was a water nymph who took a mortal as her lover, who swore that each one of his breaths would be a testament of his love for her. After he committed adultery, Ondine, or her father, in some versions, cursed the cheater to stop breathing the next time he fell asleep, hence the term Ondine's curse, otherwise known as congenital central hypoventilation syndrome, and suffers lack of the function of the autonomic nervous system, which regulates breathing. This means we'll consciously have to remember to breathe. And there are people who do have. And if you go on the internet, everybody likes to call this so romantic. They have like Ondine's Curse website for people who have this problem. I like the little teeth there. That's a nice little touch as well.
Next slide, please. In Ondine's Curse, neurological damage abolishes the autonomic but not voluntary control of breathing. People with Ondine's Curse must remind themselves to breathe, and they cannot go to sleep without the aid of a mechanical respirator.
And that's the last of the clinical applications. We can ask questions of our own for the rest of our time. And if you want to ask questions from early in the semester,
Oh, I plan on it.
you can do that too.
You guys are getting ready for the final. I get to have all sorts of fun.
When they hold their breath, do they not feel like they need to breathe?
Well, we're talking about the chemoreceptors. So the chemoreceptors give you the need to breathe. If you didn't have your chemoreceptors saying, take a breath, take a breath, take a breath, you kind of go, I don't feel good. You just feel the effects.
So if they forgot, they would just pass out on the floor?
If they forgot, they would die in their sleep. They'd die in their sleep. I mean, if you're awake, you say, I don't feel good. Oh, when's the last time I took a breath? I'm bringing it back, going fine. But, you know, if you're asleep, you wouldn't know, and you just gradually and die.
I feel like I have that problem, but I don't have it while I'm sleeping. But a lot of times I'll realize that I haven't taken a breath in a long time, and I feel really
Yeah, there's another condition coming up in our clinical applications called sleep apnea, and I've had lots of roommates who've had that. You read in the book, and you go, okay, Brad, come on. Another breath here. You know? And they wouldn't, sometimes they go like for a minute without breathing. And you have to get up your desk and go over and thump on them. Say, take a breath. But, yeah, that's sleep apnea. You have roommates like that?
Just never thought to go thump on them.
You throw a pillow at them. That'd be too.
All right, so our own question time. First question, what gives alveoli their ability to withstand stretching during exercise? Elasticity, yeah, but what gives them the elasticity? This is a throwback to a lot earlier in the semester and was mentioned in this section. One thing that was mentioned directly is the basement membrane. All right. So what if basement membrane wasn't a choice, though? What other terms could you use to describe that? Okay. There are type 4 collagen fibers is one of them, and those are part of the extracellular matrix. So those are a couple other terms you could use to describe. what's going on there with basement membranes.
All right, so we're going to kind of talk through a system. Let's say somebody has, they're going on this new fad diet. And this new fad diet, they're like, I am not going to eat any salt anymore just because, this is my new, caveman diet or whatever they do out there. So they don't eat any salt at all, and their blood starts to get a deprivation of salt. What is going to first initially detect this decrease of salt in the blood? Say that again? Osmoreceptors. Receptors. What else in the kidneys would? There's an... Good. Juxtaglomerular apparatus. So the juxtaglomerular apparatus is going to detect, hey, the salt concentration is low, and it's going to secrete something. What is secreted by this? Renin. It's going to convert angiotensinogen into what? What converts angiotensin 1 into angiotensin 2? Angiotensin converting enzyme. Now this helps to increase the blood pressure in two different ways. How? What are the two ways? Vasoconstriction, so you have peripheral constriction increasing the blood pressure. What's the second way? Aldosterone. Where is aldosterone being secreted? Adrenal cortex. And what is going to, what does aldosterone do? Good, retains water and salt.
There's a question that leaped to my mind here that just begs to be asked. You're using a sphygmomanometer on a patient's radial artery, and you inflate it to a high level so there's no blood traveling through the person's arm. Then you gradually use the thumb valve to gradually release the pressure until you hear with the stethoscope a soft tapping sound. Which of the following is correct about that soft tapping sound which you had in a question on your last exam? Is it associated with the lowest pressure in your arterial system? Then why did people circle that one? Okay. Is it associated with the opening and closing of the mitral valve? No. Is it associated with the activation of Purkinje fibers? Yes, because that causes ventricular systole. And the soft tapping sounds are associated. Didn't say what caused it, what was associated with it. And it was the activation of Purkinje. Most people miss that. They said it was the lowest pressure in the arterial system. The disappearance of the Kortikoff sound associates with the lowest pressure when the sound goes away. That's down about 80 millimeters of mercury. But everybody wanted to circle that it was the lowest pressure in the arterial system.
All right, we're going to have a throwback here for you. What is the name of the pigment that is most associated with control of circadian rhythms? Melanopsin. Perfect.
Melanopsin.
Good.
Melatonin would be a good distractor.
It would be. So melanopsin is in retinal ganglion cells, right? So it's not in the rods and cones of the eye. But how does the message that melanopsin create get to the brain? The retinohypothalamic tracts. Perfect. So those are activated by photoreceptors that contain the pigment melanopsin. And where do the retinohypothalamic tracts go in order to control circadian rhythms? The suprachiasmatic nuclei. Perfect. Where are they located, incidentally? Near the hypothalamus. Good. Lots of fun stories.
Here, where in the cell would you expect to find transcription taking place? In the nucleus. Good. What if that wasn't an option? The organelle that contains DNA. Good. So there's actually two organelles that contain DNA, though, right? What's the other one? Mitochondria. Good.
All right. I'm just trying to think back on your Throwback Friday, if that's even a word. So there's an area of the brain that I'm thinking of that contains upper motor tracts. What area of the brain found in the frontal lobe we'll make it easier. What area of the brain found in the frontal lobe is going to contain upper motor tracts? Very good, precentral gyrus. So you're looking at this precentral gyrus and you like see that central sulci and you know are folding through your little gyri here, and you go back to the postcentral gyri. What does it do? Somatosensory. What does somatosensory mean? Say it louder. Tactile senses, also coming from, you could say, your tendons or those stretched tendons that are going to be there. Very good.
Okay, here's going to be a motivational one. Something you can have your weekend thinking about this way. We learned about theta waves. Theta waves have been measured on an electroencephalograph. What are adults doing when they have theta waves? What are adults doing when they have theta waves? They're what? Close enough for me. They're sleeping, okay? That they are sleeping during that. But that wasn't going to be the question. I'm building up to the question. So decreased activity in what network in the brain is responsible for people going into theta wave activity? Decreased activity of what network in the brain is responsible for people going to theta wave activity? Decreased activity of the RAS, reticular activating system. Very good.
All right. I'm trying to think of the best way to ask this. So, as you know, there are two divisions of the autonomic nervous system. What are those two divisions? Sympathetic, parasympathetic. Correct? Not a choice. Sorry. Fight or flight and rest and digest, or feed and breed, which I think is better. Correct? Not a choice.
Craniosacral division.
The craniosacral division and thoracolumbar division. Those are great multiple choice ones. So craniosacral is the parasympathetic, and the thoracolumbar is sympathetic. So those are fun. But that wasn't really my question. So associated with the thoracolumbar division of the autonomic nervous system, there are small branches that branch off from spinal nerves soon after they exit the spinal cord and go to ganglia. What is the name of these small branches from spinal nerves, and where are they going? Not quite. They're not going to muscles. They're going to ganglia. Any ideas? They would be preganglionic, that's true. So I'll give you a hint. They're going to the sympathetic chain of ganglia that runs parallel to what is the name of the branches from the spinal nerves as they enter the sympathetic chain? The white rami communicantes. What is the name as it leaves that, goes back into the spinal nerves to go out to the body and do its thing? Anyone remember? The gray rami communicantes. Isn't it fun?
Doesn't everybody know that?
Hey, what condition decreases lung compliance by scar tissue buildup, and how does this affect the vital capacity? Good. Fibrosis, and since it's lungs, you would say pulmonary fibrosis. So how does that affect the vital capacity? It's going to reduce it, right? Because vital capacity is as far as you can inhale to as far as you can exhale. And if you have scar tissue in your lungs, you won't be able to stretch as far to inhale or exhale as far. Now, while we're on the topic, what can cause pulmonary fibrosis?
Was there an occupation we heard about? Coal mining.
Coal mining, good. And when it's caused by coal mining, what term would describe that condition? Black lung or anthracosis. anthracosis.
Man. All right. So I'm trying to branch things together, so bear with me. I remember on the first test we were talking about cell membranes. We were talking about transportation across cell membranes, and there was a couple classifications. Give me some classifications of transportation across cellular membranes. What types do we have? Exocytosis, endocytosis, or penocytosis. What else? Active transport. Give me an example of active transport. What does that mean? Good. Sodium, potassium, ATPase. Give me an example that we have learned recently of the sodium, potassium, ATPase. Yeah, but a sodium potassium one we've talked about. Blood pressure. Think about blood pressure. Digitalis. Yeah. Think though blood pressure, aldosterone. Would that work in the kidneys as well? Okay. So what about also simple diffusion? What type of things go with simple diffusion? Huh? Aquaporins. What hormone is most responsible for aquaporins? Is that secreted by the adenohypophysis or the neurohypophysis? Neurohypophysis. So let's talk about also some more channels. A voltage-gated channel. Where would we find a voltage-gated sodium channel? Neuron. Very good. So let's say we're going to be at resting membrane potential, which is what? Negative 77. We reach threshold. What is threshold? Negative 55. And then what opens? Sodium channels. It's going to spike up. What is going to open once it reaches potassium channels? So as these action potentials are going, it's interesting. We talked about how they can kind of skip across and allows it to go a lot faster. What was the name of that skipping that allows it to go very quick? Saltatory conduction. What is most responsible for that, or most associated with that? Nodes of Ranvier. And I heard that over there? Myelin sheath. Both very good. So
What makes the myelin sheath? Schwann cells and
oligodendrocytes.
Schwann cells isn't a choice. They're also called neurolemocytes.
And last question I'm going to ask, this action potential as it's going, it goes in one direction. What keeps it going in one direction as opposed to going backwards? There's a couple things, but name them off. Refractory period, very good. What else? Ball and chain of the refractory. And there's something else that I'm thinking of as well that can keep it going. Think of multiple neurons.
A series of neurons. Something acts as a gate.
Snare protein.
What acts as a gate? So things only go in one direction through a series of neurons. The receptors are only on the postsynaptic.
Good. So exocytosis of neurotransmitters going and docking to the receptors found on the postsynaptic neurons.
Okay, let's just try something that may happen in your future. Let's say it's an upcoming summer holiday, and you're meeting with a relative who has a stooped over position and a rigid body posture, and he kind of shuffles, and he's also trembles with his hands. You think, I think I've seen a picture of you in a class that I just had. What's the name of his disease? Parkinson's. Okay. Parkinson's is caused by a deficiency of a monoamine. What monoamine is deficient? What dopamine system is often defective in people who have Parkinson's? Nigrostriatal dopamine system. And people who have Parkinson's are often treated with L-DOPA. What does L-DOPA do? Absolutely correct, because dopamine doesn't cross the blood-brain barrier. So L-DOPA does, and it's converted to dopamine in the brain. But it says here in the notes they're also given MAO inhibitors. What the heck are MAO inhibitors? What do the initials stand for? Why would you give a monoamine oxidase inhibitor to somebody with Parkinson's? Because it would reduce the breakdown of the dopamine neurotransmitter and they would have improved function. And the monoamine oxidase inhibitor, where is that enzyme located? Inside the cytoplasm or inside the presynaptic bouton. I was having fun with that too. Presynaptic bouton.
All right. Also, just piggybacking off what Andy said, what can be one of the negative side effects of taking MAOIs in high doses? Depression, symptoms of schizophrenia, perfect. It's interesting how schizophrenia and Parkinson's seem to be on a sort of continuum where schizophrenia, there's too much dopamine, and Parkinson's, there's not enough. So I've had my hand at trying to write a fun little two-door question. We'll see how it goes. So what ion is vital to the exocytosis of molecules that stimulate nicotinic receptors?
What ion is essential to the endocytosis?
Exocytosis.
Exocytosis.
Calcium. And calcium is doing what?
That's right. It binds to something. What did it bind to?
I heard it. Binds to synaptotagmin. And what does synaptotagmin do at that point?
What's the name of those proteins?
Snare proteins, perfect. And the snare proteins are what let the neurotransmitter out.
And I have a follow-up on that one before we give it to Zach here, building up. Speaking of the snare proteins, did we learn about two different proteases that affect the snare proteins? Name both. Botulism toxin and tetanus toxin. Yeah, both are proteases.
Okay, what cell structure is essential in helping clear mucus out of the conducting zones of the pulmonary system? So it's a mucociliary escalator. What cell structure is that made of? Lots and lots of cilia, good. If we're thinking smaller, right, what inside a cell helps form cilia and lets them move? Microtubules, good. And how are those arranged? 9 plus 2. Where in a cell would you find the 9 plus 0 arrangement? Flagella also have the 9 plus 2. So the 9 plus 0 is only in the cell's primary cilium. Each cell has one primary cilium that nobody knows what it does.
Just really quick, the way you can remember that is the 9 plus 2 is what's actually allowing movement of the cilia or flagella. So if anything moves, then it has 9 plus 2, and if it doesn't move, it's 9 plus 0.
All right. So we were talking about calcium. There's a whole lot we can do with calcium. No, actually, no, I don't like that question. Never mind. I'm going to a different one. What is most responsible for uterine contractions in women? Oxytocin. Very good. What else would oxytocin do? Milk ejection. What is going to be stimulating milk production? Prolactin. What is the name of the condition in which someone would want to put exogenous oxytocin-like chemicals into a woman? Preeclampsia, very good. What was the name of the system that is going to be releasing precursor hormones to the pituitary gland? What system would this follow? Let's say with the circulatory system. Very good. Hypothalamo hypophyseal tract, or if it's circulatory, hypothalamo hypophyseal portal system. What two hormones are secreted by the posterior pituitary? Oxytocin and vasopressin, correct, not an answer. Antidiuretic hormone. And let's ask one more. What hormone is most associated with development and growth of a child? Huh? Growth hormone, human growth hormone. What if I said correct non-answer? Somatotropin. And they're going to be stimulating what area of the bones? What is that, anatomy? Never mind, epiphysis.
As I recall, Jurgen likes to go on foreign travels to foreign countries. He always has his eye out for attractive women. So at any rate, he's in an exotic country on his foreign travels, and he meets a very interesting lady with fairly prominent canines who's bathing in a pond in water. And he's quite smitten with her and says that he will love her with every breath that he takes. And it turns out that he was unfaithful. And so this woman cursed him with her own name. What was the name of the curse? Ondine's curse. Ondine's curse. I like that.
All right. This is a fairly straightforward question. What is the name of the severe condition in which glycosaminoglycans accumulate in the subcutaneous tissues? No, but that was a good guess. Not atherosclerosis.
Big bags under their eyes, puffy, edema.
Myxedema. Perfect. And what is myxedema? A severe hypothyroidism. Yes, it's a severe type of hypothyroidism.
Which types of nucleic acid participate directly in transcript or translation? So RNA, which types of RNA? mRNA, tRNA, and ribosomal RNA, right? rRNA. Good.
All right. So we'll go back to my calcium question. So we were talking about calcium with the snare proteins causing exocytosis. However, we also talked a lot about voltage-gated calcium channels with muscle contractions. So where would calcium bind to start a muscle contraction? Troponin C. Troponin C is then going to move what protein away from a binding site or an active site? Tropomyosin. Tropomyosin is then going to move away, and then as Andy says, the sex-crazed myosin heads are just going to go at it. However, what is most associated with the what is most associated with the power stroke? Good, the release of the inorganic phosphate. What is most associated with cocking that head? Say that louder. Splitting the ATP, so going from ATP to ADP. What allows us to release the myosin head from that actin? Say that louder. Addition of ATP, very good. So this calcium, it's coming in, let's say our action potential comes down, it's going to open up channels that are on that membrane protein and exogenous, well, it's not really exogenous, calcium in the extracellular region is going to be coming in. What receptor opened to allow that to come in? Dihydropyridine receptors, very good. And they're going to come in, they're going to trigger another channel to open. What channel was that? Ryanodine, very good. And those ones come from what organelle? Still there? Sarcoplasmic reticulum, very good.
Okay, I'll ask the last question of the day. And again, a lot of questions can be deceitfully easy sounding. So, what makes gamma globulins? What makes gamma globulins? Plasma cells, not a choice. B cells, not a choice. What's that? B lymphocytes, not a choice. What's that? You're still not there. Think back to the beginning. Back to the beginning.
A cell that comes from the myelin tissue.
Think bigger.
Back to the beginning.
Or smaller, I guess,
How about
technically.
ribosomes? Ribosomes make hemoglobin?
Or
So-
enzymatic.
Yeah,
Or
ribozymes.
nucleic acid that exhibits enzymatic activity.
Rough ER, subunits from the nucleoli.
30 or ADS
Yeah.
molecule.
A lot of people forgot we
floating in
went
the
back on what
cytoplasm.
makes proteins. Yeah. So good luck. Study over the weekend. We'll see where we get to by Friday of next week. Thanks for my panel of experts here.
I have to work next Friday.
Oh, pretty sad. You've got actually have very good questions. So.
Now I don't know who to steal my questions from.
I hope you guys continue to do this in professional school. Say, let's get in a group and quiz each other. What if that's not a choice? What if that's not a choice?
I got my position on the wait list for Wisconsin.
You what?
Got my position on the wait list for Wisconsin. I'm in the top quartile, which means
Top
somewhere.
quartile.
And they don't only tell you quartiles. So somewhere in the top 40.
Okay.
So it's a pretty
I'll
good
keep my
chance.
fingers crossed for you. It'd be nice to choose the one that is going to be more economical and closest to family.
It's hard because it's St. Louis or Milwaukee really are my choices.
Okay.
And St. Louis is a slightly better city, I think, for me and experiences that I've had, but Milwaukee is a slightly better school.
Okay.
So it's
Well,
kind of a toss-up.
my
right?
wife, when she was getting into nursing school, she accepted one in El Centro in southern end of California. And she found out that whatever school you go to, you can create your education. And she came out the best in her class. So, yeah. I think you will do the same. So.
Also, I was meeting with Dr. Tarbert today, and so my questions are there, but I just sent them to you.